I'd like to start with introducing, I'll introduce first Damien, and then he'll have about 10 minutes to speak. Damien Browning is the Executive Director of Steps to Recovery Homes, a nonprofit organization that he co-founded in 2013 and built from the ground up. It provides safe and structured environments free from alcohol and drugs for people who have substance use addiction. Damien has firsthand experience with addiction and has been in recovery since 2006. He's a member of MATForce, where he currently sits on the steering committee. He also serves as a reentry and community coach. And I just want to add that my personal interactions with Damien over the years have been very positive, and Damien and his operation are such an asset to the Verde Valley. Can't say enough about that. So with that, Damien, go ahead.
Thank you so much, Lori. Can you guys hear me?
Yes.
So I'm Damien Browning, like she said, Executive Director of Steps to Recovery Homes. My ex-wife and myself founded Steps to Recovery Homes with 3 credit cards. In 2013, we wanted to help people, and we just started, actually it started as a halfway house, and we just wanted to put more, we wanted to put more tools into people with addiction issues so they can actually find long-term recovery. And it's grown into kind of like a hybrid. We're more of a structured sober living now. It has been, August will be 8 years. Right now we have a women's program that is focused totally on health and wellness. And we have a men's house. We have a resale store that we started 6 years ago to kind of help the nonprofit Miracles Happen resale store. We have a job development program. When people come into our, usually about 97% of the people that we serve come in with no money, and we bring them in and we put them into job development if they want. And we actually provide, we help them with resumes, we help them get their social security cards, their birth certificates. We help them do mock interviews with them for people that volunteer from the community, business people. We get them clothes, haircuts. We build the resume, we do career assessments. There's a handbook they go through that's called What Color is Your Parachute? We have a whole curriculum that they go through. So for the first 2 weeks, they actually go through some soft skills, building, getting ready to find out what they really want to do in life, because I feel that connection is the opposite of addiction. And one of the things that people with addiction issues have is they don't think they can do anything different or do what they really want to do. So when we can kind of change that conversation with them and get them to actually find a purpose and empower them, then actually can help them with long-term recovery. So besides doing life coaching and giving them doing budget financing, talking to them about priorities, goal setting, behaviors, we focus more on behaviors, attitudes, and perceptions. We focus on getting them to be accountable in communication. After the first 2 weeks, they go into a hard skill job development setting to where we have a warehouse, we have an eBay, we have online sales, we have the store they can work in the office. And then usually about whenever they're ready, about week 5 to 7, they can start looking for a job. And we try to help them to actually focus on, the triggers and stuff in the workplace. Like, when they're working, they get anxiety and stuff like that. So when they're working with us in a recovery therapeutic environment, it actually helps them out to kind of address some of those things in early recovery. So we've kind of grown. We do a lot more than just house the people. First of all, our places are very, very nice. We have a savings plan where we half their money. So when they get out, they have some money to move. It's a 6-month program. They can stay up to 18 months. We have a transitional house also. We actually help furnish their apartments because we have a store. We give them clothes. We give them gym memberships. We take them to equine therapy, kayaking, camping. Out of Africa, we used to take them segwaying. So we do a whole bunch of stuff to kind of get them to feel like they can have fun in recovery. And I think one of the reasons that our program works so good, but right now I just did our statistics again, we're at 50%. And the way I do statistics is I look, every year I go over everybody, a lot of them become family, and I'm very involved in the recovery community. So most of them I stay in touch with. This last time I had 80 people that I didn't know where they were, so I just put them on the negative. So I really don't know. Some of them have relapsed, but they're back to actually, they're not in jail. They're actually being a productive member of society. They're actually clean. They're back on the track. So that's kind of how I do my statistics. So it's kind of like a long-term recovery. You know, are they doing better? Did they learn something from our program? And I do that yearly. So statistics are a weird thing, as we all know. I mean, I just was doing, there's a thing that came out that 93,000 people died last year of an opioid, of an overdose, and that's 255 people a day. So this is a big thing. Addiction is on the rise. The pandemic has made it even worse with isolation, and you know, we're just doing the best we can to kind of combat that. Right now, we are moving to try to buy our own. We have our own. We own the men's house. Well, we're buying the men's house. We were donated the women's facility. So we have a women's facility, a men's facility, and we're looking to buy our own building so we could put all of our eggs in one basket, I should say. So with our own building that we're looking to get a loan from USDA for, we'll actually have our job development under there. We'll have our warehouse. We'll have our eBay online sales, our offices, and we just got a grant from Health First Foundation to start an IOP. So we're getting ready to start an intensive outpatient program. So our whole curriculum is going to kind of change. So the first, what we're planning is the first 3 months, they'll actually be going to therapy and doing job development before they step out and they actually get a job. So actually they're more ready. Their success rate for long-term recovery will be maximized, and we'll build a better workforce in the community. We'll, you know, help families in a lot of ways, help our neighborhoods, help a lot of stuff. I want to give a shout out to Barbara Luttrell. She was an amazing woman. She mentored me on a few different occasions, and she was just always willing to help. You know, we here at Steps to Recovery Homes, we're very understaffed, underfunded right now. You know, we do our funding right now is we get a couple grants, and the store brings in some money, and we do some fundraisers. We do, you know, and I usually do an Erase the Stigma Day, which last year we weren't able to do any of our fundraisers or Erase the Stigma Day. The Erase the Stigma Day is one of the things that I put together that I was really proud of, where I have a day that we bring in booths, and we have about 5 to 7 speakers to talk about addiction and mental health and how they go together and what to do about it, you know, because when a crisis hits, it's, you know, we need the resources out there for the families, for the people, to employers, for whoever that has to deal with in everyday life. And a lot of people have some kind of addiction issues in their life, whether it's their neighbor or a niece or a son or a mother or an employee or an employer, or, you know, we're all touched by it. So it's just a huge issue. I'm very grateful for the Mental Health Coalition. I'm really grateful that you guys are continuing to have these Mental Health Mondays. And we're just willing to continue to put this together. My hope is in the next 5 years that this will be a sustaining organization for years to come in the Verde Valley, where people can come that don't have the money for affordable recovery that focuses more holistically on all parts of somebody's life, to actually put them in a good path to be content in life and have a purpose and be a solution in our community and in their life, you know.
Much appreciated, Damien. And I can't think of anyone that is more dedicated, just on every level, the time and what you give to all of this. So thank you so much. So we'll move along now, and I'll introduce Greg Billi. Greg is the CEO of NASCARE, a peer and family run organization that operates wellness centers and housing in various locations, rural communities throughout Arizona. He serves on the Access Arizona Behavioral Health Planning Council and has an MBA from San Diego State University. I might add that I believe that NASCARE just celebrated their 19th anniversary, and I will turn this over to you, Greg.
Thanks. Nice to see everyone. It's nice to be able to talk about NASCARE's housing. It's a little different. what we have is independent housing that we work with people with SMI, can be general mental health and recovery. A lot of times those are co-occurring disorders. So our housing basically works. It's people have to have, we're not funded for the housing itself. So people have to have some form of income, but usually most of the people that are in this population that we serve have some form of SSI, Social Security, something like that. So our program is pretty inexpensive because we have a program. We put them through, part of their requirements are to go through different groups and individual services that we have. And how it works, to give you guys an idea, is we do have standalone day centers that are just not for anyone who lives there. They're just day centers. And then we have housing, which is connected to the day centers. The population works with them, but while they're integrated, they're also separate. And what that means is people that come to housing have to have some form of stability, because it is, we have staff there during the week. On the weekends, sometimes Saturdays we have staff, but they have to be at a place where they can be there alone on the weekend, be alone there in the evening. Their housing itself, when people are, what I call an integrated program, because people are living together, a big part of the program is reducing social isolation. So that's just a key kind of theme across what we do with our housing. Some of our people have different emphases. Some are more just mental illness. They have issues that they can work on, that they've improved on over time being in our housing. Some people have more recovery issues. Some people have obviously a combination, because that goes together. We have people that a lot of times are family members. So we may have a son or daughter of parents that, the person needs support, but they're able to live independently. We have some people that have, they're somewhat homeless. They've been homeless. It's not a homeless program, but there are a lot of people obviously in this population that have times when they're homeless. So we have people like that. We've worked with people, some people in probation. It just depends on their background. So just to give you guys sort of a idea of the different people we serve. Also, one of the things I think people that we have, it's important for us to communicate, is that because we're an independent type program, is we're not where someone comes straight out of a facility. And I think that's hard sometimes. Let's say someone is in an inpatient or a strong residential program, 24-hour program, and they come straight out. They're most of the time not ready for, a completely, kind of our program, which is supported but independent. So usually they have to have, a little more stability to do that. We do work with people that come out of group homes, residential group homes. Like, we'll work with them and they're ready to come out. So we do a lot of that with people where we transferred them into our program. That's a common thing that we do. And to give an idea of what we try to do in the housing is, because the people are learning to live together, they're learning to be social. So they have their own meetings in the housing. They have to do certain chores. They do their shopping. They kind of have some teamwork in what they buy as a group, working together. They go out together. That's part of the housing. Then they're integrated into centers, programming with the centers, with other people. They go out in the community. They have all kinds of groups. It could be budgeting. It could be, mental health with triggers, substance abuse, because we work with, we have a 12-step style program. We work with a lot of, all the issues with the substance abuse, because it all goes together. So they go through, we have, nutrition, diet, nutrition, all of those kinds of things. So that's where we integrate with them into our centers, and they have so many hours a week. They kind of have combined with what they do with their groups, and then their individuals. So we do, again, group support and individual support, because that's important. And so, for an example, we have people, we do room inspections. Why? We have people that have some hoarding issues. That's a problem, right? That's more of SMI type problems. So we may work with someone like that. We've helped people with helping them, keep on their eds, medications. We collaborate with their case manager when they're having trouble, help keep them out of crisis. If they're having a problem, we can connect them over to their case manager or to a crisis type thing. Medical things, we've had people, we've had a person who we helped get them, they had no teeth, they got their dentures. Their self-esteem went up. They were very excited about that. When it comes to recovery, helping them keep on track. Part of, keep having them in that housing program, having them socialize, checking their room is to help keep them on track so they stay in their recovery. And sometimes, we are a complete, drug-free program. That's what we are. Every case is individual. You may have someone who's maybe faltering a little bit. It's legitimate. We can work with them. So, everyone we work with, of course, is case by case. Their background is case by case. But what we do is, we're in Prescott, we're Prescott Valley, we're in Cottonwood, we're in Kingman, we're now opening in Casa Grande, Arizona. So it's a unique population because there's a lot of people we serve that we have in housing that they have an independence. They can do some living by themselves, but they really need support. They need support in a lot of areas. And that's kind of what we do. We're kind of a unique program and we kind of fit in that niche. So just to give you an idea, that's how it works. And, we have transportation because that's what we do. We transport people, so we can transport them even to doctor's appointments, depending on what their needs are. Like I said, to the store, to centers. And basically we're about wraparound services and giving support on all the areas that someone needs. Because again, a lot of times all of the recovery, the mental health, goes together. We've had people that have some paranoia. We had someone that finally moved out of our program. They had paranoia. Being in our program, they gained a lot of independence. They gained more confidence, and they were ready to move on. We've had people with jobs. We have a number of people that work. It's usually not full-time, part-time. We've helped people with their resume, help them. We've had people that have not had the confidence to work at all. So we've given them the support in that way to, get their resume, look for a job, get what skills they need to do that. So we try to cover a broad area of life support to build them up independently, to help them stay on track with their recovery, their mental illness, and gain the skills to socially interact with others, to be able to interact with others, and to be able to ultimately, live on their own as much as possible. And again, like I said, because we're connected to our day centers, if they do move out, they can still come back to our day centers. So they are connected. That's kind of nice. And that's pretty much how our program works. And I assume, again, if you guys have any questions, please ask, because I think it's a very powerful program and unique, and we definitely like to, we have housing for people that need it.
Thank you, Greg. It's a whole lot going on there. And we're glad to hear that you're opening another housing in Casa Grande, which that's exciting as well. So, and anyone who has questions, we'll be opening up for questions after we hear from Eric. We'll let Rose introduce Eric.
Hi, Eric. So he's Eric Marcus is the executive responsible for social determinants of health programs at Health Choice Arizona, which is a regional health plan organization and the Northern Arizona Regional Behavioral Health Authority. Prior to his current position, he served as the NARVA Institute's Chief Administrative Officer, where his responsibilities included leading the Sustainable Economic Development Initiative, which is this is NARBA's economic development subsidiary. And also Well North Communities, their permanently supported housing subsidiary. So Eric, we'll let you tell us everything you're doing regarding the housing.
Thank you very much, Rose. Can you all hear me?
Yes.
Good. Okay. Well, let me say thank you to Lori and Candy and Rose for the opportunity of speaking to you today. And let me also extend my thanks to our previous two speakers, to Damien and to Greg, for the incredible contributions that they and their organizations make to this community. I really applaud all that you are doing. I'm going to just spend my 10 minutes trying to take you through housing programs for members with serious mental illness in Northern Arizona, which was the request I had. Well, let me start out by just saying that housing is healthcare. And one of the things that we did earlier this year is we documented what that really means. So for example, we took about 250 of our seriously mentally ill members and looked at their healthcare claims 1 year before they entered housing programs, and then looked at their healthcare claims 1 year after they were in housing. And as you can see, there's over a 16% decrease in healthcare claims costs. That's $1.1 million. That's a significant reduction. And not only is that a 1 year savings, but I think we can pretty much predict that that will continue as long as they continue in housing. And I think that's critical. And a major element of that is the wraparound services that are offered by our housing providers. Housing all by itself is not sufficient, but with the wraparound services, it makes a huge difference. And what we've seen, as you can see on this slide, a 33% reduction in inpatient care, a 19% reduction in behavioral health crisis services, and a 60% reduction in chemical dependency residential services. These are really critical. And it really, I think, demonstrates the fact that housing is healthcare. So when we look at what kind of programs that we are providing, and I know that David Bridge is at least listening in on this call, so he's our partner in this at Access. And through our work and partnership with Access, we offer rent subsidy programs with wraparound services that are currently administering housing through our network of providers, which includes people like Greg at NASCARE. We are administering housing for more than 464 members with serious mental illness or substance use disorder. And we have been able to increase the number of rent subsidized units by more than 20% with the same funding that we have received for the last 3 years. And that is a testament to the high quality of housing network providers that we have, that we've been able to just squeeze every penny out of every dollar. We also provide, in addition to permanent supported housing, move-in assistance, security deposits, utility deposits, eviction prevention funding. As you can see here, several hundred members have benefited from what we've been able to provide. I wanted to highlight 3 programs that I think are worthy of your consideration. First is Emerald House, which is operated by Child and Family Support Services in the Flagstaff and Prescott Valley areas. This targets young adults with chronic high users of emergency services. And it is really designed for young people 18 to 25, 26, who are in large part coming out of some kind of institutionalized setting. It could be an institution, it could be foster homes, but they're not ready for independent living. And without this support, they would be floundering. And Emerald House provides that support. And you can see some of the outcomes here. 76% transition to employment, 82% finish their education, and 100% are actually living successfully independently. If I look at our Closing the Gap program, which we fund and is operated by Catholic Charities Community Services, This specifically targets chronic high users. So we're looking here at law enforcement, people with heavy reducing law enforcement encounters, the number of times people get arrested, people get incarcerated, reducing emergency department encounters. And we see some of the outcomes. Length of stay, 9 months on average. 40% who have exited the program have actually increased their income. That's more than double the industry standard. And that's a testament to the quality of work that Catholic Charities and our healthcare homes are providing. And then lastly, I just wanted to target or talk about the programs that we have with reentry, where we are working with justice involved members as they come out of the jail system. And I know Bea Thayer is on the call. She is one of the people that really founded this program when she worked for Health Choice in NARBA. And this is significantly reducing recidivism, and 25% of individuals who exit the program actually increase their incomes. This year, because of COVID, we were able to apply for and receive COVID-19 emergency housing grants from HUD and served over 270 people through Flagstaff Shelter Services and Catholic Charities Community Services. I'm very proud of the work that both of these organizations did in putting up temporary hotels, temporary shelters, and really being able to serve our community. That's my 10 minutes. I'm happy to respond to questions. I'm very proud of the more than 16 providers that we have for housing across the northern region. We cover Yavapai, Coconino, Mojave, Navajo, Apache, and the northern half of Gila counties. Very pleased with what we've been able to achieve in these areas, and I'm very proud of our network and what they've been able to do. Turn it back over to Lori or Candy.
Okay, thank you so much. Great to get a little overview from each of you. And we'll open it up now for questions.
I have one in the chat, Lori.
Okay.
Greg, they wanted to know what your current vacancy rate is.
Yeah, I don't know if you guys saw, I did answer the chat there. We have
sorry.
quite a bit of vacancies, right now. But I will say, the thing is really we're dependent on referrals, and our population is not a immediate crisis. We're not a lockdown facility. So there's a massive population out there of the SMI and recovery and these types of people that need a place to live. They could use independent living and go to services and groups that give them that wraparound support. But we are not a residential place where we can bill, so we need referrals, and for us to be able to bill and sustain the program. So if we can get referrals, we're here to to fill up our housing. So that's kind of our the biggest thing that we need.
So Greg, this is Lori. So what you're indicating is that your housing is reliant on referrals from the health homes. They have to come in from a health home, or they can come to you.
Yes, and also, correct. And we're also not like a higher level of care nursing home. Sometimes we've had some people that have been in our housing that either they're given to us or they become, they may have incontinence issues and issues where they need care or a higher level of care. We're not that kind of facility. So, yes, that's what we need is referrals from health homes for the population, people that need support, all kinds of family members. They need that independent support. They need that living. But for us to be able to give them the support and put them in housing and wrap that all around, we definitely need the referrals from the health homes.
Greg, this is Rose. I just wanted to find out, do people need to be on access to qualify for being a resident in one of your homes?
For the program, yeah, they do, because we bill for our services. For example, when we do trigger management, when we do, all the groups on recovery and health and all that, that's what we do. We bill access, we bill for those types of services.
And Greg, are they
Now for their,
are they required a certain number of hours per week to be in the wellness center so that you can get that billing?
yeah, we usually have like 13 hours a week total, which includes their housing. It's not much. And they could have family members. We've had fiduciaries, pay there. It's like $400 a month, which includes their housing and their utilities and everything else with the program. And so it's not much. And we've had fiduciaries and other people that can cover that kind of thing if they want. But for the services, yes, it's like 13 hours a week. So there's still time if someone wants to do volunteering, they work at a job. We have a number of people to do that. So we try to make it flexible enough and, give them enough time to be able to meet a program, which they need. If we didn't have the programming, we would just be housing, which wouldn't be giving them the support they need to be successful and move forward.
Okay, thank you, Greg. We've got a couple other questions coming up in the chat. We've got our wayward mentally ill daughter is 42 years old. It seems like services don't apply because of her age. How do we get her the help she needs? She doesn't qualify for access. And anyone on the panel want to answer that? Maybe, let's see, she's come home to older parents who cannot care for her. And I'm wondering if Eric, because, the housing programs that you oversee don't maybe require access or so, I don't know if anyone would want to.
Well, yeah, Lori, I'm happy to respond. The first question I would have is if, first off, age shouldn't be a factor. Age might only be a factor in the Emerald program because it is designed for young adults. But 98% of what we offer in terms of housing programs have no age restrictions for adults. So that should not be a factor. In terms of being mentally ill, I'm not sure how Mr. and Mrs. Doheny are defining mental illness. If their daughter has been diagnosed as seriously mentally ill, she is likely to qualify for access. We don't know if she would qualify under Title 19 or not Title 19, but she in all likelihood would qualify for access. And so she might want to go to one of the health homes. I don't know where you're located, but you could go to a place like Spectrum, Southwest Behavioral, the Guidance Center. Any of those would be or if they're in Prescott, I think you just wrote in there, you could certainly go to West Yavapai Guidance Center and see if they can provide assistance. They not only have housing, but they also can help determine if your daughter should be qualified for access or if she should be diagnosed as seriously mentally ill. And Damien, thanks for putting in West Yavapai Guidance Center, but I will also add, I believe they've changed their name now to Polaris. So you may see it down as Polaris. I would strongly, or Polera, thank you, Lori. So I would strongly suggest starting there and seeing what they can do. They have a housing coordinator. They have the clinical support that's necessary. I think that would be the best place to start.
Yeah, thank you, Eric. And you bring up a good point about access. If someone is in the SMI, seriously mentally ill population designation, access will cover their medications and some things. If they are not T19, these are things that out of this call, we can certainly provide you more education about. Kathy, you've had your hand up, and then we'll go
Thank
to
you.
Kathy after that.
This question is for Eric, and Eric, I'm a little confused because I'm hearing that people are having difficulty in getting housing. There's an unofficial wait list, and yet we have NASCARE that has available housing. So where is the problem? Is it the type of housing that they're offering? Is it the health homes just are refusing for some reason? I just don't get it.
Okay, so let me respond to your question. First, occupancy exceeds 95% among our health homes, so it's high. And you're never going to get to 100% because people do move out and places have to be cleaned and refurbished. So there's always a small amount of time. The question about what is a health home, let me just hit that real quickly and I'll come back to your question, Kathy. A health home is a facility that provides integrated health care. Spectrum, West Yavapai or Polera, Southwest, the Guidance Center, all of those are considered health homes. In terms of housing, yes, NASCAR has vacancies, but the reason they have vacancies is because they have a program and you need to qualify for their program. Greg outlined that, and I'm sure he can give you more information about it. They would love to be, I'm sure, at 100%, but they rely on referrals and they rely on people who meet their qualifications. So many of the people that we house would not meet the NASCAR requirements. Maybe they have difficulty in terms of clinical needs or acute care needs. So what I will tell you is that for the most part, we're at capacity. There isn't an unofficial wait list. There's a real wait list, okay? And that wait list is on the Housing Management Information System. So if you look at the HMIS, which is coordinated by the COCs in each county, maintain an ongoing by name wait list. And every effort is made to try to place everyone we can.
What is the number now on that wait list? Do you have an off the cuff estimate?
I don't know offhand, I'm sorry.
Statewide, I had heard 3,000 at one time. I thought that was phenomenal.
Yeah, I mean, there's substantial need for affordable housing. For example, it's not just for the seriously mentally ill community. It's for everybody. And one of the things that Health Choice, along with the other 6 managed care organizations that serve access in this state have done is we formed an organization about a year ago called Home Matters to Arizona. And we are committed to raising $100 million for affordable housing statewide, a combination of both debt and grants. And in fact, we're already over 35 million now in less than 2 years. You can go to Home Matters to Arizona. I think it's .org. I'm not sure if you Google it, you'll find it. There's a tremendous shortage here within Arizona and nationally for affordable housing, period. Yeah. Now, when we move to housing for people, so David Bridge just announced in the chat, 2,800 to 3,000 statewide housing list. It's significant. Just look around in this area, trying to find housing just for workers in Sedona, okay, is significant. Sedona has literally thousands of unfilled jobs. And the reason they have thousands of unfilled jobs for the most part, in my opinion, is because there's no place for people who are making $15, $20 an hour to live in the area. So we have a significant affordable housing crisis, and that crisis affects people with serious mental illness at least as much, if not more, because now not only do I have to get the price right, okay, but it is also critical to find landlords who are willing to rent to people who have serious mental illness. Now, we make the case all the time by going to landlords and saying, look, first off, many of the people that you deal with are undiagnosed suffering with mental illness, okay? And you know that from your years as a landlord. The benefit that we bring to you and that our housing providers bring to you is we have a middleman. you have a health home that you can go to a coordinator to or to a case manager, and they can help you if you have a problem with a tenant. And we're going to do the best we can to keep that tenant housed. We work closely with our landlords, not just our housing providers, to ensure that there's continued service. And I'm just looking at David's chat, talking about not putting all your eggs in one basket. Absolutely. It's not just about housing that we can provide through access. It's HUD housing, it's COC housing. There are all kinds of programs, and it's critical to reach out to everybody.
Thank you so much, Eric. Katie, you've had your hand up. Go ahead, Katie.
Thank you. I have two questions. The first one is for Damien. I wanted to know, are there any in-person dual diagnosis meetings? And the second was for the gentleman, the last gentleman, I believe it was Eric, had mentioned part of the program includes diminishing interactions with law enforcement. And I wanted to know kind of like the specifics and examples of how that works.
Katie, that's a good question. I don't know of any, but I'm sure there's some. I'm sure that would actually, Greg might know of something like that, or Spectrum might have some things like that. I'm sure somebody on this meeting has some information about a dual diagnosis meeting, but I don't know of any.
Okay, how about just meetings that are for, like, I've been diagnosed, I don't mind sharing. I'm a schizoaffective and alcoholic. So it's like, you know, trying to address both issues in a meeting, or just maybe going to a meeting that's more geared toward mental health issues, is really hard to find something like that.
Yes, yeah, yes. And I personally, I don't know of any. There has to be something out there, though. I could look into some information and see if I can find anything, but I'm sure there's something out there.
Okay. Yeah, thank you. And then the last question was directed towards lowering interactions with law enforcement with the mentally ill population.
Sure, and I'll respond to that. First, we strongly encourage, though we follow a housing first model, which says that treatment and housing are not dependent. But we strongly encourage all of our members to be in regular treatment programs. So case managers at places like Spectrum, at West Yavapai / Polera, at the Guidance Center and others, they are trained to be able to help through an integrated care plan to keep members from requiring either ED services or law enforcement services. The program that I was talking about in particular is one that's offered by Catholic Charities. Right now it's offered in the Flagstaff area. It's called Closing the Gap. And you're certainly welcome to reach out to Catholic Charities, and they can tell you if they have any openings at the present time. It's a small program. They have 2 houses that each hold up to 6 people. And the challenge is funding. We provide as much funding as we can for them. But if there was more funding, we'd be able to offer more of those programs. And it's a very intense set of wraparound services that include care management, treatment services. It's an integrated treatment plan that addresses all of the needs, a whole person for our member. I hope that answers your question.
Okay, thank you.
Katie, did you see? I just put a link. There is actually, it's called, wow, where did it go? It's called Dual Recovery Anonymous. And I just put you a link to their website. They have meetings.
Oh, that's so cool. Yeah, I'm working off of my phone, so I can't really see much.
Okay, well, look it up. Dual Recovery Anonymous. I'm sure they have Zoom meetings too. So I don't know if there's any local, but most 12-step fellowships have a lot of Zoom meetings going on right now. So
yeah,
I'm sure you can find something.
Wow, I appreciate it.
Katie, I will email you that link after the meeting.
Okay, super.
Actually, I might mention, Katie, I am out of town. If I don't have your email, I'll do it as soon as I get back into town. But we'll
Oh,
get you that. We'll get you that, or you can also Google it.
Okay.
Are there other questions?
I have a question for Damien and for Greg. Damien, what is the capacity with your housing? How many, what is your, if you're at 100%, you said you've got a women's residential and several different housing. What is your capacity?
So we have, we can hold 14 guys at my men's facility. And we can hold 5 at the transitional. Our transitional is full. Our men's facility is full. We've turned away 4 people in the last 3 days looking for housing. Our women's facility is brand new. It's going to be able to hold 8 women. Right now it holds 4. We have 3 in there, and we're training a house supervisor before we bring in another woman. And then I'm hopefully within the next 2 months, we're going to be able to hold another 4 women when I get my house supervisor trained. And then we have a downstairs apartment that has a mother and her child in. And if she ever moves out, which I don't know if she will, we're going to try to keep that for women and children. So right now we're pretty much full. I have 1 spot for women, but I'm not totally comfortable until we continue the training with my house supervisor to bring in more women. And I'm hoping within the next 2 months we can bring in 4 more women, and then hopefully with our IOP we will be bringing in some money, and I'm going to try to purchase more housing, because it's just we turn people away all the time, and it's upsetting, when people really want help.
Absolutely. And within what you just said, there's a piece about having to have enough staff to provide the services in a safe way with qualified individuals. And nationally and statewide, there's a shortage of behavioral health staff. So
Well, there's a shortage of staff everywhere, but nobody wants to work, that's the whole thing. But like with the state having sober living licenses now, and we're always trying to up the bar on our recovery homes. So we want everybody properly trained. We want to provide a really good service, quality service. So.
All right. And I just want to mention, if you are not speaking, please mute your microphone, mute yourself. That's always appreciated. And Greg, what would your full capacity be with the number of different housing locations that you have, if you were full?
Well, in Prescott, we have a 14 capacity for 14 people. Cottonwood, 6. In Kingman, we've done some remodeling of various things, so probably around 25 in that area. So there's quite a bit there. In Casa Grande, 6. So.
Okay, that's good to know.
Kind of general idea.
Okay.
So I have a question. If I'm not interrupting, if someone else had a question I didn't notice, I'm wondering for our 3 speakers, as advocates in the community, what can we do to help with the housing issue? Because personally, I hear this all the time. Where can my loved one live when they're needing additional help?
Maybe knowing of our programs, like if someone asks you that, telling them, hey, if they fit, let's say in our program, these are available, are you on some form of access, connecting them to us. Maybe get a little background. When someone asks you, I'm in this situation, maybe try to get a little background on what their situation is. So it might help you guys, kind of refer them, know what program might be better for them. But we're always open to just having someone call us, because the worst that could happen is they don't maybe they don't fit or qualify, right? But it'd be better to send people to us, and because we do a lot of interviewing and a lot of, we try to work with them as best we can, and the parents and whatever family members and supports they have. So, you could always just send them over and we'll do our best to see what we can do.
Yeah, and I think just so you guys know, I mean, it's not just people with addiction and homelessness that are having the housing issues. The housing issues are everywhere. So just keeping it open and talking to people that might have a house available that wants to help with programs like this, keeping the resources out there, keep talking about it. But I think the city, hopefully, I think the city's looking into some housing solutions too, but everybody, you can't find, I mean, like my guys coming out, my guys and girls that complete the program, they can't find housing. There's no housing available for a lot of people right now. And if it is, it's really expensive.
Very true, very unfortunate. George, you have your hand up. If you'd like to unmute yourself.
Thank you. I wanted to share that here in Maricopa County, if you're looking for housing, you should start with your case manager or a peer support specialist where you're receiving services. I recognize there's a big difference between Title 19 and non-Title 19, but that's a good way to get the ball rolling. Now, because our clinical teams have housing specialists, could I ask how it is in Prescott and Flagstaff? And thank you very much for all the work.
Thank you, George.
Do our clinics have housing specialists?
Yes,
his
they
question.
do. Spectrum, West Yavapai, Southwest, all have housing managers.
Is that new, Eric? Because when my son came up to Northern Arizona in 2017, the local clinic said they couldn't help him unless he had been homeless for some period of time.
I don't know the answer to your question, but to the best of my knowledge, those three have had housing managers prior to 2017. So
Okay.
I'm not sure why you were given that advice. It could have been that they didn't have any housing, and that was their reason, saying that they, in prioritizing people for housing, that they didn't have any at the present time. But they certainly could have referred to the COC or to the network of other providers. So we don't give up.
Okay.
I think that, what George said about starting with the case manager is really important, because that case manager would be connected to that housing manager associated with the clinic that they work within. And it's my understanding from a presentation that I saw David Bridges provide a while back, that the housing that Eric, you're talking about with subsidy and that individuals aren't required to be in treatment. They can get into that housing without being in treatment, but it is, as you had also said today, highly recommended and encouraged for them to engage with the clinic, but not a requirement.
That is absolutely correct. Okay. Now, that doesn't mean that there aren't housing providers who have programs that require participation in the programs, but generally speaking, to receive funding through access or through our sources, you have to adopt a housing first model. Housing first is a model, anybody who wants to can Google that. It's a HUD term of art, if you will. And what it basically says is the most important thing is to get you into housing first, okay? And then we will work on trying to persuade you that treatment is a good idea, okay? And that in fact, we know from our experience that people who get housing and don't go into treatment or don't have wraparound services are not nearly as successful as those who do. So there are plenty of good reasons to be in treatment, okay? But our providers who receive funding are committed, okay, to providing housing first. And that means that they do not restrict housing to those who are receiving treatment.
Thank you. And I'm not seeing any other hands up right at the moment, and I don't want to interrupt anybody either, but I have another question for Damien while I'm waiting for other hands to go up. Damien, you mentioned looking for a facility or moving everything in under one roof when you find the funding for it. Do you have a location in mind?
Yeah, we are looking at 2 different locations right now.
He's not going to reveal it because he's afraid someone will go run over and buy it right away, right, Damien?
Well, I don't know. They're pretty expensive, so I don't know if anybody's just gonna run over and buy. But today, in today's market, you never know. It's like you can't even. I know somebody looking to buy a house, and it's like every time that she even goes to look at it, it's already sold. It's like bam, sold.
Okay,
They'll both be in Cottonwood.
they'll
So
both be in time.
I mean, both the places I'm looking for I'm looking at are in Cottonwood.
Yeah, and earlier to Bill and Pamela's response, I did put in the chat that you can contact NAMI Yavapai through any of our websites, and we will assist you to, at least to some extent, in answering these specific questions and maybe helping you navigate the system, because it's not easy. It's not clear, and it's not easy, and it's hard when you're in a crisis to navigate what's going on, and how to get the help that you or your loved one might need.
Thank you, Candy. I spoke with you on the phone about 2 weeks ago, and I'm so glad to be here.
Oh, I'm glad you are too. I'm glad you are as well. Okay.
Any other questions? Candy and I are speaking at the same time, asking the same question.
Yeah. Kathy, you're on mute.
I haven't totally formulated this in my mind, and I don't mean to be too challenging, but I am just not understanding why, especially in Northern Arizona, up in Kings, what is it, Greg? But I was up there 2 years ago, and you had a lot of housing available that was not filled. And I just don't understand why this is such a persistent long-term problem. I understand you're not getting referrals, but what is it because you have to bill for the program? I mean, what are the other housing people doing different that you can't do or you don't want to do?
Okay, no, it's what we can't do. First of all, we can't bill access for our housing. We don't bill a residential rate. We have no billing, that we can do. That's number one. So we bill for services. And I know, I don't know, to be politically correct, I think a lot of it is we provide services, peer services and all that. That's an integrated part of housing. It's the support. That's what the wraparound services, all that is about. And I think a lot of it's being held in house. I try not to bring it up, but if we're talking about this issue, that's just my opinion. We try to outreach, we try to market. I know there's a massive population of people that none of us could serve all together. We know that. And there's tons of people we serve that are they're not just an immediate rehab emergency crisis. There's that, because they come out of those places. I mean, they're not there forever, right? They need support, and there's all kinds of people that across the spectrum that are out there that need this. I mean, it's to me, it's an overwhelming need, but I think that's what it's about. If you ask me, I mean, quite honestly, I think it's, and I've talked to, lots of people in my industry, and there is a trend to me, trying to move more of this in a one shop stop in-house type thing. And maybe
well, I guess I feel part of it is choice, but the other piece is just I feel very sad.
Yeah, but I
that
still
there
think,
is, that there is all of us, how there is stuff available. I mean, 20 something beds up in northern Arizona. I mean, that's phenomenal. And yet it's not being utilized, and that's sad to me.
yeah, it's sad to us too, because it's a great program. I mean, we have people we really, really help a lot, and at many different levels. It's truly needed. The families, the individuals, but we just can't do it because we need a referral. You know, we have to have that referral to Bill to keep the program sustainable. And I know there's a massive population of people that need it. And so yeah, it's tough for me to understand, because I think there's plenty of people that need to be served. And so yes, it's difficult to understand, but it's very hard for us to get referrals.
So what I understand is that you can get you can get someone and provide services, like up to 10 days, but then you need the referral. And at that point, you're not getting the referral, even though you've been effective in providing the services up to that point. And so I'm hearing from other, like FIC and other agencies, that's where they lose the person, because they can't get the referral, even though they are a good match.
That's one of the issues, yes. And then the other issue is, remember, we don't have direct contact with a lot of people. So if a lot of this population is not being told of our services, told that they can, you know, with the type of housing programs that we have, we don't have any direct way to connect with them other than trying to find out a way to outreach to them. So it's not like a lot of these members have a clear-cut thing that, hey, did you really know this is available to you? Do you have this? You know, their family members, I don't think know. And, you know, relying on the marketing is going to come from the health home to them, that these types of things are available. So I think if there was some way to connect with families and individuals, you know, of families that need these services, that would help a lot, because that's another issue, is, you know, being able to connect with people and let them know it's available.
No other questions? Comments? Wow, I guess we solved all the problems, you guys.
Yeah, I'll make a comment. I'll just one last little comment. So since no one else is in Maricopa County, we had a lot of these similar problems, and it wasn't that they had to make the referral. It's just we didn't have the health homes, but the providers just were not making the referrals to the peer runs. And, you know, we worked with them and we worked with them, and, you know, very slowly it started to break, where they started to see, you know, the feasibility, and that we all could work together. So in you know, central and southern Arizona, we don't have the health homes. We don't have that block, you know, to the referral to the peer and the family runs. And I you know, I don't think we have any statistics, but I think we've worked much better together, the two communities.
I think that you bring up a good point, Kathy, and one thing that has not perhaps been mentioned that is related to this is that it's my understanding that of all the health plans in the state of Arizona, Health Choice is the only one that does require a referral. It doesn't allow self-referral. And I think that you know, that just is something that can be noted. There's a difference in the north, and with only 2 health plans in the north and a great number, 7 to select from in other parts of the state. They're different.
You only need a referral if you're SMI. If you want to get physical health services, you don't need it. It's only one population that's been targeted for this.
Exactly. And Denise, you've got your hand up.
If I could just interject before Denise comes in. You know, I am not on the clinical side. I'm on the housing side. So I can't tell you what referrals are required or not required. But I can tell you that every member in every Health Choice member, and we're the Regional Behavioral Health Authority. So in terms of people suffering from serious mental illness, they are all part of the Regional Behavioral Health Authority. And I am unaware of any differences in terms of referrals between the regions. But I can tell you that each member who has been diagnosed as seriously mentally ill has an assigned health home, and they should be working with that health home. If they feel that they are not getting adequate services from that health home, okay, I strongly recommend that they take a look at their health choice card, their Medicaid card, and there's a phone number on the back. It's a toll-free number. They can call in. They can say, I am a member who is suffering with serious mental illness, and I don't believe I am getting the support I need from my health home. I strongly recommend that they start by talking to the health home to see if they can get anywhere. I mean, there's case managers have supervisors, and you can certainly talk to them. But if you reach a point where you feel you are not getting the services that you want, that is something that Health Choice as an organization is there to do. We take any issues of grievance or complaint very seriously. We have very short timelines that health homes have to respond to us, and we will address them aggressively. So if you feel that you are not getting the service you need, you should reach out to us.
Eric, you just opened up a whole nother can of worms. We'll save that for another day. The fact is, and Access is totally aware of it, the consumers are afraid to complain. They're afraid of retribution.
Yes.
So Denise, you had your hand up. You'll need to.
Thanks, guys. Greg, I would really like to touch base with you about expanding your visibility. I have some ideas. For example, I could coordinate a presentation, like if you would like to do a presentation to Flagstaff Shelter Services, to the shelter in Flagstaff. I understand that if they encounter someone living in the shelter who might benefit from your program and that person is not currently enrolled with the help home, that there will be some hoops that have to be jumped through. But if you have any interest in presenting to shelters, there's the shelter in Bullhead, there's Flagstaff Shelter Services. As well, I have contacts with local coalitions to end homelessness throughout the balance of state. And we can coordinate presentations where you can coordinate directly to the continuums of care, which is the COC that Eric was talking about. Because what I'm hearing, and Eric can tell me, or David, if I'm not hearing this right, but the coordinated entry system, which is through the Arizona Department of Housing, which has its own by name list for housing, doesn't really interface with NASCARE or with the access list. So if the people keeping those by name lists in the local counties of people that are homeless, if they know about NASCARE, then when they've got this person, they're discussing this person, they're through case conferencing, and they're saying, Joe is experiencing homelessness and he's also got these other issues and he might be a good fit for NASCARE. They're not going to have that discussion if they don't know about NASCARE. So another way to promote visibility for your programs is I'm happy to build those bridges to increase visibility for NASCARE, because it is a tragedy. We have people who need housing, we have slots open, and the connections aren't being made between these two systems. So if there's anything I can do in that area, I'm happy to. And I also wanted to know if NASCARE does out of area referrals. Let's say somebody in Page meets your criteria, but the closest place where you have an opening is Kingman. Can we work around that? How can I help you with that? I've got connections to working in Health Choice in all these different counties. And so I'm really happy to do anything I can to support more visibility. So, we can talk offline, but if any of that sounds useful, let me know.
Okay, I'll connect with you. Thanks, Denise.
Yeah.
All right, thank you. Thank you so much. And David has said in the chat, Southern Regional Behavioral Health Authority is piloting a coordination between systems that seems to be effective. We'll keep our eye on that. And I think that we're looking at hopefully forward movement to assist people into housing and expand housing.